Hello, and welcome to Dermatology Weekly, the official podcast of MDedge Dermatology, where we discuss issues that most affect the specialty. I'm MDedge editor Elizabeth Mishkati. And now, your host for this week's Peer-to-Peer, Dr. Vincent DeLeo.
Today, we're talking to Dr. Robert Brodell, Dr. Cindy Smith, and dermatology resident Alexandra Streifel. Welcome to all of you. Can you please introduce yourselves for our listeners?
Hi, everyone. I'm Cindy Firkins Smith. I'm a dermatologist in Willmar, Minnesota. I also am a clinical professor at the University of Minnesota in Minneapolis, and I serve as the Vice President for Rural Health in Centricare.
I'm Bob Brodell. I'm chairman of the Department of Dermatology at the University of Mississippi Medical Center. I'm a professor of dermatology and professor of pathology. I do dermatopathology in my spare time. And at the University of Mississippi, we have a big interest in access to care, hence my invitation to your session. Thanks, Vince.
And my name is Alexandra Streifel. I am a 2020 graduate of the University of North Dakota, and I will be completing my dermatology residency starting next year at Louisiana State University. And I'm a very interested prospective rural dermatologist.
Thank you all for joining us today. So let's get started. Why has access to dermatologic care in rural areas become such a growing problem?
Yeah, I'll take that one. It turns out that there is an increase in the number of dermatologists per capita in urban areas. There's also an increase in the number of dermatologists in rural areas, but the rural increase is much smaller than the urban increase. So the difference in the ability to access a dermatologist is a growing rural problem.
So thinking about this, what factors influence some young physicians to establish clinical practice in geographically isolated rural areas? Wouldn't that help?
Yes.
I'll take. Do
Cindy,
you want to go that?
No, go for it.
Yeah, the best way to secure a rural dermatologist is actually to start with someone who grew up in a rural area. The data clearly suggests that rural people move back to rural areas. So we have found out that rural dermatologists tend to be born and not made. Having said that, there aren't enough rural-born dermatologists, so we need to rely on people who are born in suburban and urban areas to come out and join us in rural dermatology as well. And the way we've found success in that is to ensure that they have the opportunity to experience rural dermatology, come out as medical students or come out as residents, and see how wonderful it is to practice dermatology in a rural geography.
Yeah, that's been our experience in Mississippi too. We have an academic rural office in Louisville, Mississippi. I'm going to say in the middle of nowhere, but I may get in trouble with Dr. Bird, who runs that office. But it is 90 miles from the mothership. And we have rural residents who commit to 3 months of training each of their 3 years in general dermatology in Louisville. We also have other residents that elect to do a month here and a month there in rural Mississippi. And they all absolutely love it. They say that they do more surgery. They see very interesting patients, often people where access to care issues have led them to wait to get to the dermatologist. They love going to the dermatologist's house for dinner at the end of practice. They love pheasant hunting on the weekend, duck hunting, going to the creek and knocking out the beaver dam that's flooding some farmland, and many, many other experiences that hiking, fishing, shooting. There are so many things that make them see that a rural life can be a very wonderful life. And now we really need to hear from Alexandra, who's maybe had her own experiences.
Yeah, so I'd echo a lot of what Dr. Smith and Dr. Brodell said. I'm a proud multi-generation North Dakotan, and we Really, I would say our density of dermatologists is pretty low for our state because, it's very spread out. We have a lot of rural surrounding states. And so, growing up, I, as a patient, experienced, the lack of access to specialty care, as does my family and friends. And then when I was a medical student, I was interested in dermatology, but thought maybe, I'll do something different down the line. And when I was doing my rotations, I got the opportunity to rotate through a lot of rural sites. And I really was drawn to the kind of generalist challenge of being in rural medicine that, you're kind of it, you have to be prepared to see anything that walks the door. You have to be, I think, very resourceful because of, the lack of other specialists in the area. And so that was a big motivating factor for me. Deciding, where I would like to end up is I want to be somewhere I know I'm going to make a big difference, and, help the health of my community, and also somewhere where I'll be challenged to really employ all of my faculties to help my patients. And, as Dr. Brodell said, there's definitely a beauty in rural life that, I think that you can't get in a city. I love the outdoors, and all the things that you mentioned in Mississippi are things we like doing in North Dakota as well. So, those were all the factors that really came into play in my decision to pursue dermatology in a rural area when I'm in practice.
I just want to say one other thing, Alexandra, come to Mississippi.
No, Alexandra, come to Minnesota. We are happy to share rural dermatologists all across the country. Dr. Brodell mentioned Adam Bird, who is now a rural dermatologist in Mississippi. He actually rotated with me on a rural rotation when he was a resident at the University of Minnesota. So ultimately, we'll try to all lure Alexandra to our homes so that they can serve our patients. But ultimately, if she ends up in rural dermatology anywhere in this country, we'll be thrilled.
Yes.
Oh, thank you.
Well, having been born and raised in White Castle, Louisiana, a town of 1,200 people, I'm embarrassed to say that I've spent my career in New York City and Los Angeles, but I still
It's
appreciate
never too late, Vince. It's never too late. Come on out. We've got room for you.
Everyone should realize I spent 28 years in Warren, Ohio, a small little town in the middle of nowhere in northeastern Ohio, and loved it. And only the lure of academic medicine made me jump ship and try something else.
I think that's probably, I'm sorry, how a lot of us rural people end up in cities because we are interested in academics and teaching. And so that fulfills it by taking us out of that area.
So
but
now wait a second, Vince, though. I'm still in academics and in rural medicine. So you can have it both ways, and so is Adam. It's not an either or.
And the University of Mississippi is going to set up an office for Alexandra in rural Mississippi.
Oh.
So just saying, you can be an academic and be in rural medicine.
Okay, all of us country folk need to focus here, all right?
Yeah,
so you
recently,
you're publishing an incredible research paper about a review that you guys did. You reviewed the curricula related to rural dermatology and telemedicine experiences at all of the accredited residency programs across the country. So can you highlight some of the key findings for us?
Absolutely. Our research, as you stated, Dr. DeLeo, was focused on viewable online curricula and assessing real opportunities for residency trainees from each program in the that's ACGME accredited programs. And our findings were that there is only one program with a specialized rural track training for residency trainees interested in rural medicine. And we also looked at population size for each program, as working with a rural population while in training may influence eventual rural practice selection. And there was a small percentage of programs that were based in rural areas. And then also looking at possibly elective options as well that could be used to do a month of rural medicine for resident trainees that are so interested.
That's very interesting, and I suggest that our readers go to the incredible table that you guys put together with the results of this. You also asked about telemedicine, and I know that the VA has extensive telemedicine experience. Can you talk about what you found when you looked at telemedicine training in the curricula of all these residency programs?
Absolutely. So how we analyzed telemedicine, knowing that the Veterans Health Administration is one of the biggest providers of telemedicine in the country, was to examine which programs had affiliations with VA hospitals, which is a big component in analyzing dermatology resident training. And I think it's interesting, kind of in the age of COVID, how telemedicine will be a factor in dermatology residency. I foresee personally that it's going to become even more of an important component of residency education. And I think having the Veterans Health Administration and seeing how broadly available it was for residency trainees is really only going to increase in interest. And I wonder how that's going to translate as well to rural access.
I think that's a great point, Alexandra, and I would suggest that 2 years from now, you redo this study looking at telemedicine and see how that's changed in the curricula residency programs because of what we're all doing in telemedicine. So finally, what do dermatology residency programs need to do to attract more students willing to pursue clinical practice in rural areas?
Well, Vince, I think that is really easy, and I have a strong bias. I think you need to actually recruit people who come from rural areas. The best way to get someone to go to a rural area and stay there is to make sure that they love it to begin with. So that's number one. Number two is to ensure that they have rural opportunities so they can get out into rural areas and do a rotation and do all of the wonderful things from a life standpoint that Dr. Brodell already spoke to. And number three, and the most innovative, is to do what Dr. Brodell has done at the University of Minnesota and create a rural residency track where you actually recruit rural people right into a rural residency, set them up and set them on the path to a successful rural career. And I'd be interested in anything else Dr. Brodell might add to that.
Yeah, I might add to number one, regard to recruiting, that the match is somewhat of a barrier to this, because we're talking about making a big investment, maybe starting in a student's first year of medical school, mentoring them, training them, writing papers with them, getting them to do rural rotations, and we can rank them high, but when they're in the match, it is somewhat difficult to decide exactly what's going to happen to them in the end. And I think we make a big enough investment that there are ways to convince the match to take a slot out of the match for this sort of thing. And good for the student, good for us. With regard to patients. Go ahead, Cindy.
Good for patients, Bob.
Yes.
Ultimately, it's good for patients because the rural areas are tremendously underserved. As already has been said, people are waiting months to get appointments. And so if we can increase the number of rural dermatologists, it's primarily good for patients. And that's our purpose.
Maybe the fourth thing I could add is that at the University of Mississippi, we take an approach to access to care that I call all of the above. Anything that anyone is doing around the country, we want to do it in Mississippi, study it and try to figure out how it fits into the mix. So we do Project Echo, where we're educating once a month primary care doctors from rural areas around Mississippi to learn dermatology and take care of the 10 or 15 most common conditions. We have a free clinic in the Delta, the poorest part of the state. We have a free clinic in the inner city of Jackson to take care of underserved people. We have the office I mentioned that's an academic office in rural Mississippi. We do store and forward teledermatology, which my faculty love because 5 or 10 minutes, they get a lot of RVUs at night. The barrier there, we don't have the barrier of payment because in the state of Mississippi, all insurance companies here must offer telederm and pay at the same rate as they pay for regular visits. But we have a barrier getting primary care doctors to take 15 minutes to send the telederm consult. But just saying, anything we can do to expose our residents to the problem and potential solutions, we hope is going to stand them in good stead to carry on in the future.
I want to thank all of you for this really interesting discussion today. And I'm hopeful that it will engender greater thought by many people about approaching this underserved minority in small towns and rural areas all around the country. I will leave you with one personal experience which occurred. We were interviewing resident applicants this week at USC in big Los Angeles, and we interviewed a young man who will go unnamed from South Carolina. And we ask every one of them in the group that I'm in, we always say, if you had one day off and you could do whatever it is you wanted to do, what would you do? And it's usually be with my family, go to a museum, see a nice resident. He said, I'd go duck hunting. And I think he may come to USC, but my guess is he's going back to South Carolina. So I thank you all for being with us. Anything else anyone wants to add?
Yeah, Vince, and I'll let Cindy follow up in a second, but if anybody wants to email me at rbrodell, BRODELL @umc.edu, I would love to talk to you day or night to tell you how we do our efforts at access to care and the great feeling of accomplishment we get from that, and maybe encourage others to do the same. Cindy?
Bob's way ahead of us on rural dermatology residencies, but in rural Minnesota, we are committed to rural health in all areas. And part of what I do is just promote rural health in every way possible. So I'm always interested in talking to people about how they can do to expand care to the people we serve in rural areas who are desperately in need. So like Bob, my email is cindy.smith@centracare.com. And I'm happy to answer questions and get feedback and ideas on how we can better serve the people that we are here to serve.
Thank you all once again, and everybody have a good day.
That's it for this week's episode of Dermatology Weekly. The peer-to-peer portion of the show is produced by MDedge editor Melissa Sears and editor Alicia Saunders. All of our podcasts are produced by Nick Andrews and MDedge editor Kathy Scarbeck. I'm MDedge editor Elizabeth Mishkati, and this is Dermatology Weekly.